Hello, this is a short presentation on Parkinson's disease. I'm going to be talking a little bit about some of the important clinical things to remember while managing patients with Parkinson's disease, what you can do as an F1, as well as going into some of the things that are important when taking the MRCP. So what is Parkinson's disease? We've all covered it throughout medical school, but just as a refresher, it's a progressive neurodegenerative condition, and it involves the degeneration of dopaminergic neurons in the substantia nigra. Its three cardinal features are bradykinesia, tremor, and rigidity. So your typical presentation of someone with Parkinson's disease is usually an elderly gentleman. The average age of onset is above 65, and they're usually more predominant in males than females. So a lot of these patients have this poverty of movement or hypokinesia, where they just lack any movement at all at most times. Apart from this resting tremor that they usually have. When they're walking, they usually have these characteristic short shuffling steps, with the Parkinsonian shuffle with reduced arm swing, and they have difficulty just starting to move altogether. They have difficulty standing up, they have difficulty reaching for things, and they just have a difficulty in initiating any sort of movement whatsoever. If you want a video just to help you visualize what the Parkinsonian gaits looks like, this is quite a good video on YouTube. So the classic tremor that they have is usually at rest. It's at about 3 to 5 hertz frequency. It's worsened when they are stressed or when they're especially sleep deprived. A lot of these patients suffer from lack of sleep. And unlike benign essential tremor, it improves particularly with movement. So you don't really see the tremor when they're reaching for things, even though they have difficulty initiating in the first place. But when they do initiate it, the tremor seems to be reduced. And the classic thing that you see in exams and textbooks is they have this pill rolling tremor, where it looks like they're rolling like a coin or a pill in between their thumb and index finger. This is another YouTube video just to help you visualize the classic tremor at rest. And finally, the rigidity. Now, this is often described as lead pipe or cogwheel rigidity. It's very difficult to imagine unless you actually examine a Parkinsonian patient themselves and you move their elbow joint. It's like you get short, fast movements and then sudden hypertonia in between those movements. It's a classical finding, and it's almost pathognomonic of Parkinson's disease. And these are two more videos showing the lead pipe and cogwheel rigidity. Some other features you might find: Parkinsonian patients usually have very expressionless, mask-like faces. They have this flexed, hunched over posture. Interestingly, they have very small handwriting, micrographia. Again, they have a lot of problems with fine movement. They also experience a lot of psychiatric symptoms as well. They suffer from depression. Parkinson's is heavily associated with dementia. About 90% of the patients that you see on the wards with Parkinson's will also be suffering from dementia as well. And they have this classic sleep disturbance because their REM sleep is usually affected by Parkinson's. Interestingly, they have this loss of smell as well. And they're usually very tired. And they have, which is something to be aware of, is postural hypertension. This can, of course, lead to a lot of falls, especially while in hospital. So you need to be careful when you're looking at these sorts of patients. Now, something you must be aware of is drug-induced Parkinsonism. This is something that is missed quite often, even by consultants. I've seen patients on my ward who have been treated as Parkinson's for months and months, even though they've been on extremely high doses of antipsychotics, which have been causing their Parkinsonism in the first place. And when they're stopped, they suddenly return some of their basic functions. It's something that we can all pick up just by reviewing their drug charts and seeing if they're on the atypical antipsychotics, especially like risperidone or other atypical antipsychotics. The way you differentiate between drug-induced Parkinson's and Parkinson's is primarily by looking at their motor symptoms. In drug-induced, they're much more rapid onset and they're bilateral. They also don't tend to have this rigidity or tremor at rest. Unlike Parkinson's, they're more you usually have just the bradykinesia, and if you're suspecting it, you need to urgently refer them to neurology. And if the drug that is causing their Parkinsonism is an atypical antipsychotic, you need to refer them to the mental health team as well and see if there's anything else that they could be taking instead. The diagnosis of Parkinson's is primarily clinical. However, it can be quite difficult to differentiate it from other conditions like essential tremor. The clinical differences between essential tremor and Parkinson's is essential tremor doesn't have this cogwheel rigidity or bradykinesia, and the tremor is more often during voluntary movement rather than at rest. It's also a low amplitude tremor. But if they still struggle to differentiate the two, you can use single photon emission computed tomography, also known as a DAT scan, which looks more in detail at their substantia nigra for the loss of these dopaminergic neurons. The first line management of Parkinson's is usually levodopa. This is a dopamine precursor which is broken down into dopamine after it crosses the blood-brain barrier. It's usually first line if motor symptoms are affecting the patient's quality of life, like their Parkinsonism is preventing them from living a normal life at home when previously they were completely fit and well and independent. However, if patients are picked up as having early signs of Parkinson's, you can use levodopa or alternates such as dopamine agonists, which act on the dopamine receptors in the brain, and monoamine oxidase B inhibitors and catecholamine methyltransferase inhibitors, which both prevent the breakdown of dopamine in the brain. If they're symptomatic despite starting levodopa, or they develop these abnormal tic-like movements called dyskinesia, you can add a dopamine agonist as well to try and manage it, or you can add the MAO-B inhibitors or the COMT inhibitors. There's some evidence for AMANTADINE being used as well in Parkinsonian patients, however, this is limited. Important things to remember with Parkinson's. They must always receive their medication at the correct times. If they don't receive their medication, they have a risk of developing acute akinesia or neuroleptic malignant syndrome. Neuroleptic malignant syndrome, or NMS, is a medical emergency with a 10% mortality rate. So if patients have reduced oral intake, or they're vomiting, or they have diarrhea, or anything wrong with their gastrointestinal tract that would prevent them from absorbing their Parkinson's medication, you must speak with the neurologist or the Parkinson's nurse regarding alternatives. It's good to always just write on their drug chart as well when you're prescribing the Parkinson's medication. Please give this on time. A lot of trusts have stickers which you can put on the front of drug charts informing nurses that this patient has Parkinson's and he or she must receive their medication on time for it. Another thing to consider is a lot of these patients have increased frailty. Parkinson's is a poor prognostic factor, and things like DNA CPR or intubation in ICU may not be in their best interest, as they may not survive it and they may have a dramatically reduced quality of life because of it. And furthermore, patients with Parkinson's, of course, have an increased risk of falls. And when they do have falls in hospital, they need to have a full body assessment for injury. This is what you can do as an F1. If they have a head injury, you can request a CT head for them and request the nurses to do neurological observations for them until the CT head has been done and an intracranial bleed has been ruled out. If they do have a bleed in the brain, it's important to review their other medications and hold off any drugs that might increase bleeding, such as antiplatelets or anticoagulants. Some patients with Parkinson's medications can develop impulse control disorders where they have highly impulsive behaviors. They can sometimes just become violent or dangerous to themselves. This is particularly evident in patients with a previous history of impulsive behaviors or alcohol consumption. If they're experiencing excessive daytime sleepiness from their medication, it's best you advise them to avoid driving. They can also develop this postural orthostatic hypertension, so it's important that you review their other medications, see if there's anything like any beta blockers or anything contributing towards this. You can use midodrine, which is a peripheral alpha adrenergic that can increase blood pressure a little bit by increasing the peripheral arterial resistance. Obviously, consult with a senior before starting on any other of these medications. Some other types of Parkinson's medications include amantadine and modafinil. So back to levodopa. Levodopa you can use in combination with some dopa decarboxylase inhibitors, such as carbidopa, which basically prevent the breakdown of levodopa in the peripheral circulation into dopamine. So it only gets broken down into dopamine after it crosses the blood-brain barrier. A lot of patients experience reduced effectiveness with levodopa over time. So their Parkinson's symptoms might improve at first and then return. Some of the side effects that patients experience include abnormal movements like this dyskinesia, this on-off effect where sometimes the drug works, sometimes it doesn't. They can develop a dry mouth and other such symptoms I've just listed here. And it's no use using this in neuroleptic induced Parkinsonism. Like I said, patients I've seen before have been given levodopa prescribed it incorrectly as the diagnosis was initially Parkinson's, when in fact it was an atypical antipsychotic that was causing their Parkinsonism in the first place. And just to reiterate, please do not stop this medication, always prescribe it. There are some alternatives you can use, like you can use patch if they are not taking anything orally, and this again prevents some of the complications like acute dystonia that you get from suddenly stopping Parkinson's medication. Some examples of dopamine receptor agonists include bromocriptine and cabergoline. The side effects, the most dangerous ones are pulmonary retroperitoneal and cardiac fibrosis. If you're suspecting any of these, the patient will need an echo, ECG, ESR, creatinine, and chest X-ray prior to starting any of these treatments again. You need to warn them about the potential of developing impulse control disorders and excessive sleepiness in the daytime. Of course, they can start to experience some psychiatric side effects as well, such as hallucinations, because you're bombarding them with so much dopamine. And nasal congestion as well is another symptom that they can experience. Selegiline is an example of a MAO-B inhibitor. Amantadine, the other drug I talked about, that you can potentially use in Parkinson's, even though there's little evidence for it so far. This works theoretically by increasing the dopamine release and inhibiting the reuptake at dopaminergic synapses. Side effects of it include ataxia, slurred speech, confusion, and libido reticularis, which is this very typical skin rash you can get. COMT inhibitors include entacapone and tolcapone. Again, it works by preventing the breakdown of dopamine, and it can be used as an adjunct to levodopa therapy as well. The final class of medication you can use is antimuscarinics. They primarily work on cholinergic receptors. They're quite useful for drug-induced Parkinsonism. They might help with the tremor and rigidity that patients experience, and procyclidine, and these two are two examples of antimuscarinics you can use. So this is a nice little diagram to visualize where all the different Parkinson's medication works. You have the dopamine agonist working on the D2 receptors in the postsynaptic neuron. You have the COMT inhibitors and the MAO inhibitors, which prevent the breakdown of dopamine. You have the dopa decarboxylase inhibitors here, preventing the breakdown of L-dopa to dopamine before it can cross the blood-brain barrier. And you have the acetylcholine receptor antagonist as well. So neuroleptic malignant syndrome, this is the particular emergency that we must all be aware of, and it occurs a lot with atypical antipsychotics. There's so many different complications you need to be aware of with atypical antipsychotics, which is why all these patients need a very good drug chart review if you're suspecting anything. This particular medical emergency has a 10% mortality rate, and it can occur if it can also occur if they're on a dopaminergic drug which is suddenly stopped or reduced. Like I said, with levodopa, if they have suddenly reduced oral intake, they can develop this. So basically, how it works is dopamine, the huge dopamine blockade that these patients experience triggers a massive glutamate release, and this causes neurotoxicity and muscle damage. And the time frame of onset for this, from starting an antipsychotic, could be from hours to days. Some typical symptoms that they might experience is pyrexia, muscle rigidity, autonomic problems as well, and they can have this raised creatine kinase. Essentially, they can suffer from rhabdomyolysis and massive kidney failure because of it as well. And they can interestingly have this leukocytosis, abnormally raised white blood cells. You manage it by stopping the antipsychotics, and if you're on a psych rotation and you're suspecting NMS, you need to urgently call up the hospital and get them an ambulance there. You can start them on some IV fluids to prevent AKI or any kidney damage. Dantrolene is something that can be given. This works by decreasing the excitation of skeletal muscles. It prevents the release of calcium from the sarcoplasmic reticulum of skeletal muscles. Bromocriptine can also be used in some cases. And just to reiterate, please do not get confused between NMS and drug-induced Parkinsonism, and just check the drug chart if you're suspecting the former. When patients are started on antipsychotics, it's always, or restarted on antipsychotics, it's always good to restart it slowly, especially with things like risperidone or venlafaxine. It's good to slowly increase up the dose to what they were on before. And if you're suspecting it, again, with antipsychotics, always refer to the mental health team or neurology. Lewy-body dementia is also a quite common cause of Parkinsonism. 20% of cases of dementia are actually caused by Lewy-body dementia. What happens in the brain is you get these alpha-synuclein cytoplasmic inclusions, also known as Lewy bodies, and these occur in the substantia nigra and the paralimbic system and the neocortical areas. It's quite confusing because dementia is also seen in Parkinson's patients. And 40% of Alzheimer's patients also tend to have Lewy bodies in their brain. So it's quite difficult to differentiate between them for a neurologist. However, features of Lewy body that differentiate it from Parkinson's or Alzheimer's is this progressive cognitive impairment that they can get. They can have this impaired attention, impaired ability to perform executive functions, and they have these fluctuating levels of cognition as well, which is very pathognomonic of Lewy body dementia. They also have the classical Parkinsonism and visual hallucinations as well. That's a very common thing that comes up in exams, but also you see on the ward. You hear about patients that suddenly start seeing their dead relatives and they're aware of it. They can also experience other psychiatric symptoms like delusions and auditory hallucinations as well. And it's a clinical diagnosis, but it's often diagnosed with a SPECT scan like Parkinson's as well. You should avoid neuroleptics in these patients especially, so be very careful if you're suspecting this and they've previously been taking some antipsychotic medications, as this can cause irreversible Parkinson's. Acetylcholinesterase inhibitors actually have been found to be very useful in Lewy body dementia, and memantine, which also is used in Alzheimer's as well. And if you're suspecting it, call up All Persons Mental Health. They really love these sort of cases. Now, these last three slides aren't particularly important in the clinical setting as an F1, but they're important for MRCP. I'm just going to talk about the Parkinson's plus syndromes, first of which is PSP, progressive supranuclear palsy, also known as Steele-Richardson-Olszewski syndrome, difficult to pronounce. And the main feature of this that differentiates it from the other Parkinson's plus syndromes and Parkinson's is the impairment of vertical gaze. So downward gaze is often worse than upward. So they have difficulty to read with their book on their laps, or if they're descending stairs, they have no problem climbing up the stairs, but they might have trouble visualizing the stairs when going downwards. They also have Parkinsonism. They have a lot of falls and slurred speech and cognitive impairment. And they have a really poor response to LEVODOPA. Multisystem atrophy is the other common Parkinson's plus syndrome, and there are two types of this. MSAP, which is predominantly Parkinsonism, is the main feature, and MSAC, and these sort of patients usually have cerebellar signs, such as dysdiadokinesia and past pointing that they usually experience. Shy-Drager syndrome falls into this sort of syndrome, multisystem atrophy. And some features of MSA, all MSA, include Parkinsonism, autonomic disturbances, particularly like erectile dysfunction and cerebellar signs. Another important drug to be aware of when you're thinking about drug-induced Parkinsonism is metoclopramide, as it's a dopamine antagonist. Domperidone is also a dopamine antagonist, but this is less likely to cause drug-induced Parkinsonism as it does not cross the blood-brain barrier. Wilson's disease, abnormal copper deposition in the substantia nigra can cause Parkinsonian symptoms as well. A lot of patients that have just recently suffered from encephalitis can develop these. Boxers or patients that have suffered from several traumatic brain injuries can develop this condition called dementia pugilistica, which is another Parkinson plus syndrome. And certain toxins such as carbon monoxide poisoning can cause it. That's the end of the presentation. Thank you so much for listening.